This voiceover will conclude our series for the shock class. I know that it's been long, and I'm sorry about that. This is a little bit of a complex phenomenon to learn about and to discuss. So this last voiceover will discuss shock in children, DIC, and placental abruption. So we'll start with shock in children, and basically it's the same as shock in adults, so we'll really just talk about what's different. So hypovolemic shock, I'm sure you're not surprised, is probably the most common form of shock in infants and children. And infants in particular have a large body surface and their metabolic rate is higher, and so they're more prone to an insensible fluid loss. So burns, hemorrhage, dehydration are all causes of hypovolemic shock in children. Cardiogenic shock happens when cardiac output can't meet the metabolic needs of the child. And so if you'll think back to your class on congenital heart defects, some of the causes here are structural abnormalities, infections, infectious cardiomyopathy, arrhythmias, trauma, and drug intoxication. In terms of distributive shock, the most common one here, which again I'm sure you're not surprised, is septic shock. Children who are at high risk for septic shock are children who are immunocompromised or have invasive lines in. Certainly anaphylaxis, spinal injury, and drug overdose are also other causes of distributive or circulatory shock. So our goals of care are about the same as they are for the adult. We want to maintain tissue perfusion, so we're going to look at our assessment findings there and implement nursing interventions to ensure tissue perfusion, and also use those same findings to evaluate it. We're going to ensure oxygenation. We're going to be very careful about infection in terms of asepsis, and we're going to this time think a little bit more about coping in terms of the developmental level of the child. And so if we have to do teaching or even explanations, we want to be sure that we reach the child where they're at. And also important to include their parents if they're at the appropriate developmental level. Your Rudd textbook does not really offer much information about shock in children. So the information for this slide and the next one is grounded in evidence from an alternative textbook that I used. So you will be responsible for the information on both of these slides, but will not have to worry about looking in an additional textbook. When we think about how shock manifests in children, it's not much unlike adults, except that in the early stage of compensation, we find that infants and children are a little bit better at compensating than we are as adults. So that when you have an assessment finding of hypotension in a child, that's a very late sign of shock, and it's a very grave sign. And so when I say that, I mean that when their their systolic, blood pressure indicates hypotension, we know that their body is no longer able to compensate, and they probably progress very rapidly into the next stages of shock. So how do we assess that? Because we know that children's vital signs are different than adults. So there's a nice chart in your text that helps you to convert these vital signs to indicate the warning signs in hypotension. So let's use an example. So a child over the age of 1 will start with a systolic blood pressure of 70 and will add to that their age doubled. So let's take the example of a 5-year-old. We'll double the age. We've got 10. We'll add it to the 70. So now we have a systolic blood pressure of of 80. Anything less than 80 would be a sign of hypotension in this 5-year-old. Other signs of or assessment findings more specific to infants and children, of course, are depressed fontanelles, dry mucous membranes, oliguria, dry diapers. Periorbital edema is also a very telling sign in children, infants and children, and tachycardia. In my notes, you'll see that there are other assessment findings that we also see in adults. So nursing care that we provide to the child in shock, very careful documentation of I&O, and frequent measuring and monitoring of cardiovascular status, vital signs, and circulation, because in infants and children these things can change much more quickly than in an adult. Also, we look closely at the blood sugar, and the reason we do this is because particularly infants have increased glucose requirements, yet they have a decreased amount of glycogen stored. So in a healthy infant, you know that they do monitor that closely in the nursery. So in this situation where the body is stressed and the glucose is going to be called to help the cells produce energy, we want to watch that closely. Strict asepsis, that's another very important thing to consider. You'll remember possibly in the news several years ago out in the Midwest, several children in a nursery died because of an organism under the nurse's fingernails. So this is why we keep short fingernails, don't use nail polish, and stay away from artificial nails so that we don't harbor these harmful microorganisms. And then, of course, again, we think about coping relevant to the child's developmental level.
Unfortunately, there is not one chart in RUD that gives you vital sign ranges for all ages of children, but I did hunt and peck through and put the pages below where you can find normal vital sign ranges for each of the different ages of children.
We're going to move into a discussion about DIC now, disseminated intravascular coagulation. And so the reason we talk about this with shock is that there is an increased incidence for patients with shock to experience DIC, and also for patients who have hemorrhagic pregnancy complications, which is why in a minute we'll briefly discuss placental abruptions. So DIC is not a disease, it's an underlying condition of clotting, and what happens is there's usually an event that triggers it. Often begins with bleeding, and what happens that when there's bleeding, platelets and fibrinogen rush to the site of the bleeding, and they rush there to try to clot, but what happens is the body runs out of these clotting factors, and there's not enough to continue to address the bleeding that's occurring. At the same time that this is happening, the inflammatory response is producing, enacting coagulation. So we have high thrombin levels producing clots that are settling in the vasculature. So we have this paradox of bleeding and clotting. And this is a pretty difficult concept to understand. It took me years to get it. And so I would encourage you not to get hung up on trying to understand it, but just simply to know that it's a paradox of bleeding and clotting. It's a very serious and grave condition. Clients with acute DIC have an 80% or greater mortality rate. And so what's really more important to us than trying to demystify it is how do we take care of clients with this condition. So we'll go forward and talk more about that. I have included some appropriate nursing diagnoses that fit our client with DIC. Certainly you can read through these. So because one of the precipitating events for DIC is abruptio placentae, or a placental abruption, somehow it's much easier to say that, we do briefly mention it here. And so I think you probably talked a little bit about this with Sarah last year when you did OB as a hemorrhagic complication of pregnancy. And so sometimes it's also referred to as a premature separation of the placenta. And what happens is that bleeding occurs and a hematoma can form on the maternal side of the placenta. This, of course, affects that transfer of oxygen and nutrients from mom to baby. So this is very serious. Now, bleeding may be apparent. There may be vaginal bleeding, or it may be concealed. The bleeding may be happening behind the placenta, and you may see a rising fundus. Other things that you will look for, other assessment findings, would be a change in fetal heart rate patterns and signs and symptoms of hypovolemia and shock in mom. So how we care for the mom with a placental abruption, we have her lie on her side. We ensure oxygenation, including but not limited to elevating the head of the bed and administering oxygen. We monitor, of course, the fetal heart rate, and most likely the baby will be delivered at this point to risk any interruption of oxygenation or nutrients to the baby. We will replace fluids, certainly, and we will keep an eye on the well-being of this fetus throughout this process. Now, as I said before, your client may not have a placental abruption. They may have shock or another condition. But if they have DIC, here are some of the other assessment findings you may run into outside of a hemorrhagic pregnancy complication. So certainly these go back to all the symptoms that we see in ineffective tissue perfusion. Because there is blood loss, you'll see pallor, petechiae, and purpura. I like to call them the 3 Ps. Difficulty breathing, coughing up blood. There may be bleeding in the GI tract, so you may have that hard board-like abdomen or distended abdomen, blood passed in the stools. You'll see bleeding from everywhere, IV sites, incisions, the gums, the nose, ears. Typically when we see this kind of thing on TV or in a movie, that's what we see, the bleeding everywhere. Blood in the urine, irritability, changes in mental status, dizziness. And so we also will have some abnormal lab values. Now, again, there's a table in your book, and I will have the page number in the notes section. But what you will really just want to pay attention to are platelets and fibrinogen levels, which will be reduced. when you go back and think about that cycle of DIC, you can understand why. PT and PTT will be prolonged, again, because of the bleeding. And the D-dimer assay will be elevated. This is the last slide, and so I thank you for your patience with this series of voiceovers. Nursing care for the client with DIC, certainly we want to have ongoing assessment and close monitoring, looking at all those signs of ineffective tissue perfusion. Typically they'll be in a critical care unit due to the severity of the situation, and great care will want to be taken, or priority, to manage that underlying problem that's causing it. So for example, if it was a placental abruption, managing the underlying problem would be delivering the baby. Many of these interventions just look like good nursing care for someone who is at risk to bleed or has a low platelet count. So gentle mouth care, skin care, not administering IM injections. This is old school stuff that you guys have learned before. If suction is required, low pressure, nothing by rectum, no temps, no suppositories, no enemas. You'll want to monitor the abdominal girth. That's always a rising girth is always a sign of internal bleeding. Good records of I&O. If there is a peripad being worn, or an incision with a dressing covering it that's being soaked with blood, you'll want to count and maybe even weigh them. And again, monitor those lab values that we talked about, and stay in good communication with the provider as they may change. You'll want to replace fluids as well, in terms of bleeding and fluid volume loss. And so I think that's it. I'm sure that you're glad to hear me say that. I will see you in class. We will work through a series of case studies of all of these different conditions and phenomenons that we've talked about. Try not to get too lost in the reading. My intent for these voiceovers were to try to direct you to what was important. And so thank you for your time and patience, and I will see you in class.